Welcome back to the National Cancer Prevention Workshop, produced by Less Cancer. This year, we're talking about cancer prevention in rural America, screenings and healthcare for better outcomes. My name is Miles O'Brien. I am a member of the board of Less Cancer, and we are privileged to be joined by a longtime friend of Less Cancer and one of my fellow board members, Jan Carney, MD. She is the Associate Dean for Public Health and Health Policy and Professor of Medicine at the Larner College of Medicine at the University of Vermont. And she has worked tirelessly on the issue of cancer prevention. Jan, great to have you back with us.
My pleasure, Miles. Thank you for inviting me.
You're most welcome. Always welcome here. Let's talk a little bit about communication. We are in an era where I think we have this assumption that everybody's just connected all the time 100% and able to get whatever information they need. There's a couple of factors to consider here. First of all, not everybody has that capability. Number two, there's an awful lot of misinformation out there. So when it comes to rural health, this is particularly difficult challenge to solve. Why don't you, first of all, explain that? Why, in the context of a rural setting, the lack of information, the mechanisms for obtaining information are a particularly acute problem?
So first, we may not even have internet in all of our, or cell phone service in all of our rural areas. So broadband internet, and that's a challenge certainly here in northern New England, and that can be a major impediment, whether you're in rural or urban settings. Second thing I would say is that sometimes we assume there are ways that people want to get scientific and medical or health information that's of high quality, and those assumptions may or may not be correct. As an example, universities and healthcare systems and government health agencies are common sources of health information. For people in the rural areas, sometimes the most important thing is to talk to them, to ask them, and because there may be local ways that people prefer to get that information, and then if we respect those and understand that, they'll be more likely to listen to us. So I would say that's the first principle right there.
That's such a key point. We've seen time and again when we talk about the misinformation that is, out there writ large, taking aside just the particular issue of the rural setting, is that people tend to believe trusted sources, mostly people they know, right? I mean, it's really important to get down to that level because there's so much skepticism built into our discourse these days, right?
Right, and it's people they know, and I think for us, in the field to try and make people's health and lives better, we need to make sure that the people that they're talking to have all the information that's indeed accurate. So sometimes those trusted sources are in healthcare settings. So if they might be a local doctor or nurse that they trust, it could be their town paper, as an example, where they get all their information, or talking to their friends, a faith-based organization. But we need to make sure that we have a presence in those communities to get that information out there.
So that's a particular challenge, right? I mean, obviously the healthcare system is spread thin as it is, and we really need to enlist kind of almost a Peace Corps style approach to this and put people on the ground who have the knowledge, who have the credibility, who have the trust of other people to explain that, a prostate cancer screening is an important thing, for example, or whatever you may decide. What's the way to do that, though? What's the way to build such a force of people that can really make a difference?
I think we have to be really creative. And if you look at the literature, you see things like community health workers, lay health advisors, people who are not doctors or nurses, but they become health and science and medical ambassadors out in communities, can play a huge role, not only in education, but in bridging the gaps of access to primary preventative care and cancer screening, as an example.
So have you tinkered with this idea in Vermont? Do you have kind of an unofficial army out there of healthcare information providers?
We're trying to develop that. And so in a current grant that I'm working on, we have worked with a a not-for-profit organization of to help with older Vermonters, and it's called Support and Services at Home. And we basically asked one of our community partners, how do people want information? And this was around COVID and vaccines, and we know there's been a lot of controversy and misinformation around the COVID-19 vaccines. We asked them, how do people want information? And they wanted one-page flyers with cartoons and large fonts with reputable sources such as the CDC and our own health department here. So when we fed that information back in that form, people liked it very much. And so we're looking to expand that into other areas around preventative health care.
So getting the word out is one thing, and having that resonate with people is important, obviously. But the next step is to take some action. And there are other challenges that you face in a rural setting, which are, quite frankly, Vermont in the winter it's tough to go anywhere, much less your healthcare provider, especially if you're way out away from a city like Burlington, right?
Right. So the concept is linking people to access, whether that's access to information, access to health care, and thinking about transportation is really, really important. That's a huge barrier. So think about the use of telehealth. For all of the horrendous things that happened during the pandemic, we did learn some very positive things about both health professionals and patients' acceptance of telehealth, and we can use that even more than we're using now. Linking people to how to enroll for health care, that can be a barrier. Finding someone to see in your own, or at least within transportation range to find health care. Those are the kinds of things. And those are the kinds of community ambassadors, trained professionals, community health workers. I think that we need to use these proven strategies even more than we're doing now.
Well, you mentioned telehealth. That's an interesting thought. Certainly during the pandemic, if there was a silver lining, there are a few silver linings. That's one of them, is that the medical profession really leaned into this idea of consults over the internet. But as you pointed out, a lot of people don't have the internet. So it's a bit of a conundrum in rural settings, isn't it?
Right. Yeah, it is. And so I think that fortunately, there is a ton of support to try and make sure that we do have broadband all over, rural northern New England, but it goes beyond that. And I think those nuances of communication, I think some of the other things that we're trying to be creative with is experimenting with our students, helping our students learn about, are there ways to use our libraries, write articles for town papers, facilitate science and evidence-based health communication in ways that people actually want it, and to ask them and be respectful and have those conversations, not assume that everybody wants to find that information on the internet the same way.
It's interesting you mentioned town papers. Town papers are a bastion of actually good journalism in a sea of bad journalism. As we all know, that my profession has taken a dramatic turn in recent years. But town papers do the right thing as far as it relates to journalism, and they have credibility. But again, we get back to this issue of how do you get to them, because many of them aren't printing papers anymore. They're online. Right. So, once again, this idea of connectivity is so important. You go to a European country and everybody's got fiber. Nobody even thinks about it. And here we are still trying to, get reasonable bandwidth to American citizens who really at this stage of the game, it's the only way to have any sort of health equality, right?
Right, exactly. But continue to use the things that people want. So my town sends us the town paper. A lot of towns are still doing that. So if we think about systems, we're thinking about things like how can we get more of our students to be writing important topics for those papers, and what do people want to hear about? And if we're able to do that over time, we continue to build that credibility that's so incredibly important in helping people make the best possible decisions about their own health.
So what about though on the healthcare professional side of the equation? I know it's a persistent long-term challenge to get people coming out of medical schools to set up shop in some of these rural locations. What's being done about that? Is there any way to further encourage, fresh-faced MDs just out of school to make a move and make a difference in a place like Vermont?
I think there are very practical approaches. We actually did a project with one of our rural community organizations last spring and asked resident physicians here, so in graduate medical education, right before they go out into practice, and also students becoming nurse practitioners, what it would take. And we thought that it was going to say, well, we need scholarships to do this. But the answer was actually, give us a rural rotation. Give us experiences out in these communities, because we're really interested in knowing what that's like, but we don't really have that automatically in our academic programs, which are more often in less rural settings. So those are the kinds of things that we're looking at. How do we get our students and medical students, our physicians in training, and our nursing students out there in these communities to see what life and the benefits and the challenges, but also the rewards of living in some of these spectacularly historic and beautiful and peaceful and lovely rural communities.
There's so many advantages to this, and I know that there are so many healthcare professionals who find this work extremely rewarding. But as one of the real catch here is that so many of them are departing school just absolutely racked with debt.
Right.
And coming to a rural setting, there's a financial consequence to that. And what can be done about that one? That's a big issue.
Scholarships, national at the federal level, but also at the medical school level. I can just speak to some of the things that we have here. And that has been a priority of our legislature and our university here to see if we can't have some loan repayment, because the cost of education is very high. We really want students to be able to make choices about what they're passionate about, not make that economic choice, because there are a lot of loans that they accumulate throughout. So that is absolutely something that our policymakers are fortunately paying strong attention to.
The other issue which comes up when you talk about rural health disparities is the lack of hospital beds, and that's been a long-term challenge. Has that stabilized all in Vermont, or is that continuing a downslide?
I think that it's not so much the number of hospital beds, but the networking and the communication. So we do have a University of Vermont Health Network, and then we also have federally qualified health centers. I think there's more and more work to connect the academic centers with the more rural healthcare settings and hospitals. We're also doing that around the area of research and practice-based, what we call practice-based research networks. So we're actually getting clinicians involved in the kind of very practical or translational research to actually help the patients in their own communities. So I think the connectedness is really, really important here.
Yeah, staying connected is such a challenge, and there's so many financial disincentives toward doing it. One of the issues that is so important in a rural setting is the availability of Medicaid coverage. Tell me a little bit about what the situation is in Vermont. Obviously, some states are better than others.
Vermont I was the health commissioner for many years here, and that was a while ago. And Vermont was one of the early adopters of Medicaid expansion, because everyone saw the benefit of doing that for improving access to prenatal care and reducing infant mortality, then expanding healthcare access to every single child in the state of Vermont, and that was back in the 90s as an example. And then in terms of the Patient Protection Affordable Care Act, or Obamacare, we're already in a state, I think, that does an extraordinary job in utilizing the benefits of Medicaid, to help our patients here.
Given that long history of aggressive use and Medicaid being applied in that manner, are you seeing are the metrics good? Is there any way of quantifying how successful and what a good investment that is? Put it that way.
I I think that it is. I think that we see, and you have to look over the probably multiple years, and all the published reports that come out consistently over the years that look at a range of health and social indicators. Certainly, no state is perfect, and every state has its challenges, but Vermont has done very well in terms of access to health care. And I think that it's a challenging time for all states in different areas. For example, opioid addiction continues to be very, very challenging. Post-pandemic, access to mental health care services, as an example, and some of those. So the job's never done, but I think that we do have some evidence of excellent outcomes that is absolutely worth the investment to try and get people into primary and preventative care whenever we can.
So, Jan Carney, when you look at where you are and the battles you fight, are you optimistic, at least on the overall trend line?
I am. I'm always optimistic, and I think that when we take what we know and we can apply it across our state or broader across our communities, I think one of the things that we learned, one of our positive lessons was our collaborative spirit and our partnerships that we have between healthcare and public health and our not-for-profit agencies out in our communities are always working in the best interest of the health of people who live here. And I'm very proud of that. I think our job is never done, but I have confidence that in the areas where we need help, we'll figure out how to get it done.
Dr. Jan Carney, Associate Dean for Public Health and Health Policy and a Professor of Medicine at the Larner College of Medicine at the University of Vermont. You are such a great asset to the state of Vermont and cancer prevention and prevention in general. Keep doing the great work you do, and we're so privileged to have you as a friend of Less Cancer.
Thank you very much, Miles. My pleasure.
This is the National Cancer Prevention Workshop produced by Less Cancer. We're talking this year about cancer prevention in rural America, screenings, and health care for better outcomes. I'm Miles O'Brien. Thanks for watching. Welcome back to the National Cancer Prevention Workshop produced by Less Cancer. This year, we're talking about cancer prevention in rural America, screenings and health care for better outcomes. My name is Miles O'Brien. I'm on the board of Less Cancer, and we are joined by someone who is an absolute healthcare warrior out there in the trenches, trying to do what she can to move the needle for people who have lots of risk and not a lot of access to health care in this country. She is the director of the Free Clinic of Culpeper, and she has her hands full. So we really appreciate her time. Tammy LaGraff, thank you for breaking away from your busy scene there in Culpeper. As a matter of fact, we can hear some of the activity in the background. Just give us a slice of life there. What's going on a daily basis in your free clinic these days?
Hi, Miles. Thank you for inviting me to join this today. Well, we are seeing patients here today all day long from 9 to 3, and so there's a lot of action, and there's a lot of people coming in to apply to be patients, and sometimes people come in just to ask questions, and so it's busy.
Yeah, give us an idea. How many people come through the doors there, and how do you manage the flow, so to speak?
Well, we have probably, gosh, it's hard to count, but I would say between 30, 40 people come through here a day at least. And that's counting people who have appointments and people who are coming to reschedule and people asking questions. And we have an incredible staff, both at our front desk and also a community health worker who greets people and helps answer questions and direct them as well. So there's a lot of activity in that very small lobby.
Well, so tell me, a free clinic, I think the name, sort of speaks volumes about what you're all about. But do you offer care to anybody who walks across your door?
So we have four criteria to become a patient here. And the first is that you have to be a Culpeper resident. You have to be 18 or older. You have to have no health insurance, and then you meet some pretty strict income guidelines. And currently, that is that people show us their pay stubs that prove that they are at 300% of the federal poverty limits or lower.
Okay, and historically, is there a type of case that is typical, or is it all over the map?
Currently, what we see are there are 90% of our patients, and last year we saw 600 patients here at the clinic, unduplicated patients. And currently, we're at 90% of our patients who are Spanish speaking, and mostly from Central America, Guatemala, El Salvador, and Honduras. And so most of our patients speak Spanish as their primary language. Some know a little bit of English. Some speak a dialect that even our bilingual staff cannot understand. So typically that's what we're seeing here right now.
So right off the bat, you have a communication problem. I mean, Spanish is one thing. I assume you can find healthcare providers, probably yourself included, who can get through Spanish. But when it comes to some of these indigenous languages that you'd find in Guatemala and Honduras, those are quite challenging to say the least, right?
Yes, absolutely. So as you can imagine, most of our patients are dealing with a lot of health literacy issues. They do not know our healthcare system. They do not know how it works. They don't really understand how to manage chronic illnesses. So we do a tremendous amount of teaching. When we come upon more and more people who are lately showing up who are unable to speak Spanish, that really sets us back. And now what we've observed is not only are they not able to speak Spanish, they are unable to read or write in any language, and they don't recognize or understand numbers or letters. So the communication issues are big, and as you can imagine, it's very difficult to teach someone about their medications or how much to take or what time is their appointment or any number of instructions that we take for granted with most teaching.
That is it's a very steep hill to climb there, and there's so many issues to unpack here. But just finding a translator who's able to go from English or even through Spanish, if you have to some of these indigenous languages is it's very difficult to find these people, isn't it?
Yes, it is. So we are lucky in that we have quite a few bilingual staff. But for these indigenous languages, we use an iPad translation service that we call into. But we have to schedule those ahead of time. We can't just dial it up and get someone who speaks Quechua or one of those.
And I imagine if you've got an individual who has no knowledge of English, or for that matter, what knows even what a number looks like, it's not like they're making appointments with you. So they're walking in off the street, and here you have this language problem, and you have really no way to deal with it. Just walk me through how you muddle through on a day-to-day basis.
So we will do our best as to explaining and trying to use any forms of communication you can imagine to try and make that point. Occasionally we get lucky and they have either a older child or a relative who comes with them who speaks both the indigenous and Spanish. So then we have to speak Spanish and they translate it to the indigenous language. So it usually involves a few steps to communicate.
Well, oftentimes it is the child who ends up in the school that becomes the translator for the family. Well,
Yes.
let's talk about some of the issues that they present with. First of all, are they eating well? That's number one.
So typically, we do not see that they're eating well. I think that in most of the countries that they're from, they are very used to fresh fruits and vegetables. And so coming here, what they're finding is that they can't afford that. So they will buy foods that are canned or frozen meals, things like that. And so we see a lot of high blood pressure, we see a lot of high cholesterol, and of course, diabetes. Pretty typical with any doctor's office, but the piece to the puzzle that is missing again is that communication and being able to explain and teach and then get them access to healthier foods. That's also a challenge.
Big challenges there. So you're seeing a relatively young population here. These are, after all, agricultural workers who have migrated for work.
Yeah.
So I suspect you probably don't see a ton of cancer. What you're seeing are all the precursors, the causes of cancer later in life, right?
Yes. So, trying to stay ahead of all those things with all the things that we know help prevent cancer, healthy diet, exercise, all of those things, obviously. So we try to teach those things, but that makes it very difficult. And then the screenings that we do come upon that we try to teach them to do are also very terrifying to them. Anything from a mammogram to a colonoscopy, trying to explain and teach how that works. I mean, if anyone's ever gone through a colonoscopy and knows about that prep, it's complicated and terrifying. And to try and teach that, or even a mammogram, is a lot.
I can't even imagine how you get all of that across and explain that that's not going to be a bad thing when you consider what a colonoscopy is all about. Huge challenges there. Do you feel like are you making progress? Because you've been in recent months kind of surprised by this influx, as I understand it.
Mhm. Yes. Yeah, I think that we we were starting to feel a little more confused by the increased no-shows and the increased med non-compliance. And when we took a step back and realized what we were looking at and, kind of made ourselves universally aware that what we're seeing are communication issues, that we were able to kind of pivot a little bit and really say, okay, we have to go back to the basics and really start at the very basics of health literacy and finding a way to communicate just simple things. So that's where we're at, is really just sort of re I don't even know how to describe it. We sort of erased the board and started over again.
Well, yeah, communication is prevention. Education is prevention. This is right at the heart of this when you have
Yep.
a population that is just coming almost with a blank slate to you. I guess potentially, if you want to be really blue sky about it, there might be some opportunities here because you can really educate them from ground zero. I mean, is that one way to look at it?
It is. And, we have really looked at it in a way that it's a challenge that we really want to overcome. We really want to figure this out because, it's so important to the health of our patients, our community, keeping them out of the hospital, helping, the burden on our emergency room, all of that. So it has become kind of a mission for us and, just looking for little victories at this point.
Tell me, where does Medicaid fit into the picture here? Is that even a factor when you're talking about this population?
Very little. So our patients can sometimes get services for their children, CHIP or other insurances for their children, and occasionally food stamps. Occasionally some patient first for women's health issues, but unless they meet the requirements for citizenship or Medicaid, that really doesn't come into play for a large majority of our patients. So,
What about improving their diet? That would help a lot of the things you are addressing here when it comes to cholesterol, high blood pressure,
mhm.
obesity, obviously. But again, so often these rural environments are food deserts,
Mhm.
ironically, because they are there as part of the agricultural system.
Yeah.
What can be done about that? What are you trying to facilitate?
So, a couple of years ago, we had some uh, landscaping that had gone totally rogue out front, and we cut it all back and got rid of it. And we're trying to decide what to do. And one of our board members said, "Why don't you put some growing boxes there?" And so we have four pretty good sized growing boxes that we grow basics, tomatoes, peppers, onions, cucumbers, and herbs, which our patients love herbs, especially, the ones that they use most frequently, like cilantro and parsley and things like that. And then we were able to partner with some local farmers who, when they have extras, they bring them. Um, Piedmont's, the minority and veteran farmers, the Piedmont, they have been amazing to us. Anytime they have a surplus, they bring it almost weekly. Our patients just love the fresh fruits and vegetables. And we try to get some recipes out in Spanish and English that, if there's foods that they don't usually see, like squash or things that they're not accustomed to, we try to get some kind of recipes out that shows them how to use those. So
But again, recipes for somebody who doesn't, read or write or understand what a number is, that could be a problem too.
it sure is. Yep. We try to use pictures, you name it.
Wow. I'm kind of bowled over by the complexity of the challenge that you face there, but you're not alone, are you?
No, we're not. We recently, our state association, the Virginia Association of Free and Charitable Clinics, has conferences twice a year. And so we had one a couple weeks ago. And we spend a lot of time just comparing notes, other directors, other clinic patient care coordinators. And we are finding that there are pockets within the state where this is not uncommon at all, and they're seeing very similar issues.
Aside from, what you're doing, which is just, kind of tactical in the trenches, are there some big picture solutions that you think we can address?
Well, I think as we try and look at, you know, skipping all of that about communication, there are basics. There are letting them feel safe and welcome here so that they connect, so that we can stay engaged with them and they keep coming back and we can keep chipping away at it. I think that's probably the biggest picture that we try to present. And trying to make sure that we have fresh vegetables and herbs that they like, just to kind of get them to keep coming. Because the more they keep coming, the more we can chip away at all of it. So,
Well, I'm sure they feel welcome there if you're running the show. Tammy LaGraff is the director of the Free Clinic of Culpeper. She just gave us 15 valuable minutes of your day. I know you've got a busy waiting room, and we really appreciate you taking a few moments to join us for the National Cancer Prevention Workshop produced by Less Cancer. We're talking about cancer prevention in rural America, screenings and health care for better outcomes, and Tammy LaGraff is all about that. Thank you for your time.
thank you so much for having me. And thanks to Less Cancer. They really do help us quite a bit here at the clinic.
And thanks for watching. I'm Miles O'Brien for Less Cancer. Welcome back to the National Cancer Prevention Workshop produced by Less Cancer. This year, we are talking about cancer prevention in rural America, screenings and healthcare for better outcomes. My name is Miles O'Brien. I'm a board member at Less Cancer. And today I'm going to be joined by a fellow board member and a experienced maxillofacial surgeon in Warrenton, Virginia. Rob Marino is the executive director of the Fauquier Free Clinic and fellow board member on Less Cancer. Rob, good to see you again. And joining him is Sophie Oswald, who is an oral maxillofacial surgeon in Warrenton. Thank you very much for joining us as well. It's good to have you both with us. Rob, you've been with the Free Clinic for a couple dozen years, and you've got lots of stories to tell about healthcare in rural settings. This year, though, we're going to focus on an overlooked and yet stunningly, a stunning gap in the system. And that is oral care, dental care, really for all of us, but in particular for people who do not have the means to go see a dentist on a regular basis. I know, this is something that is a problem which has been rising for some time, but I'm just curious when you decided to sort of take some initiative on this and what that looked like when you finally did.
Well, since the free clinic is open that I work in, we have always had some aspect of a dental care and dental clinic. For whatever reason, people don't always associate oral health and dental care with health care in the same way that they do with primary care and medical care and mental health care. And I really think it's a shame because, as Sophie can tell you, it can really affect somebody's overall health. It's expensive. Even people who have health insurance often don't have a payer for dental care. And if they do have a payer, it's not very generous. And so it's often the last thing people take care of. And people who don't have a lot of disposable income do not spend a lot of it on prevention and going in for regular cleanings and preventive care, which has all kinds of consequences after you wait too long.
Sophie, give us a little bit of the expert's view on this. I did a film a few years back, and part of that story was a young boy actually in the Baltimore area who literally died of a toothache, which is a stunning statement in this country. But what that raises is that somehow we've created this arbitrary dividing line between the mouth and the rest of the body. And there's two groups of healthcare providers on either side of that line. And a lot of times things slip through the cracks. Just explain, first of all, why there is this kind of separation when it comes to oral health care and the rest of our bodies.
Oh, that's a big one. But I think just to make it more simplistic, oral health care is just one of those things that you just don't think it's an organ. You think of your brain and your lungs and your heart as something that's a lot more crucial. But a lot of people don't realize you have you have cardiac issues, you have respiratory issues. Everything starts from the oral cavity. And so, just from having some deep probing depth in your gum tissue, which is periodontal disease, can lead you to have a heart attack, ultimately. And so anyways, and I think that, I don't know, I've noticed in my own practice that sometimes the way that the insurances have, put the system together, for us, our insurances cover only a certain amount and not as much, and patients will have to pay a lot more out of pocket, and there's a limit on that, whereas no limit on medical insurances. So yeah, I think it's just been hard on both sides, on the patient side and on the provider side as well.
I think we can't underscore enough how serious the consequences of bad oral health can be to the person in toto, and up to and including cancer.
Yeah, I think what people now fully understand are the ramifications of like eating healthier, making sure you exercise, and that sort of type of hygiene, if you will, or healthcare, and taking care of your body systemically. But from an oral cavity standpoint, it is just one of those things that it takes 2 minutes a day every morning and 2 minutes a day every night, but that prevents so many other diseases as well. And I think sometimes we just put it on the back burner. It's unfortunate.
So, Rob, with that in mind, I presume you see a lot of patients who, frankly, have pretty unhealthy mouths, and I know you've done your best over the years, but you decided to do sort of a bit of a full court press on it recently. First of all, tell us about what you did and how Dr. Oswald helped out, and what that looked like when you kind of opened your doors and said, we're here to help you get your teeth straight, so to speak.
Well, our dental clinic is now open 5 days a week, and just recently we've started seeing actually more patients for dental care encounters than for medical by a little bit, because the need is so big there. We've added an oral surgery service because some people need oral surgery intervention and they need a difficult extraction or some of the assessments and cancer screening that Sophie can do. It's still not enough, and there's still a long wait to get into my clinic, and that's typical for a charitable clinic all over the state and the country. We recently had an event where we brought students from VCU and from Howard University and set up in the local high school gym to try and do a kind of a crash event and see as many people as we could in one day to kind of get through the backlog. We were able to provide dental care to 260 people in one day in a high school gym, many of whom had not been to the dentist in years. Some people came in and they needed a cleaning. A lot more came in and they needed some fillings or restorative work. And quite a few came in and they needed root canals or oral surgery extractions to get to a more stable place. It's really no way to offer dental care. What you want is prevention and constant, contact and a relationship with a patient, but maybe it's a front door for people to get into the system.
Just so people understand, this is a rural setting, 260 people showing up waiting in the dark, essentially, for care. That's a big turnout, isn't it?
That's probably about as many as we could have seen in that day. We had 36 dental chairs set up. I was there at 5 a.m. It was cold, it was dark, it was raining, and people were lined up waiting for free care, which is really a statement about how desperate people are for that help and how important it is.
So, Sophie, what kinds of cases do you encounter in these situations? I assume it as you say, it could be as simple as just polish them up. I suspect there's less of that and a lot more of some real work that needs to be done. And frankly, dental care, to my experience, is it's multiple visits over sometimes many weeks to do the work. How do you get enough accomplished in these short periods of time with people waiting in line?
So now for this particular event, unfortunately, I wasn't present, but I do it every year in a different location, and I go internationally to do missions as well. But how we try to do is we have different areas. So we have a triage area. When the 260 people come in, we check each and every one of them for what is the most pressing issue. If they have an abscess, so so they have facial swelling or any sort of pain or swelling, we try to go to oral surgery because that's more important. Then if they don't have any of that, they might need some restorative work where we need to do a small filling or a larger filling. And then, obviously some other minor things would be, their teeth are pretty cavity free, technically speaking, without clear radiographs, clear x-rays, then we could just do a cleaning, a hygiene appointment. So that's how we triage them. But for me, obviously, it's been a long time since I've done anything else but oral surgery. So I see the end of the line cases, patients who have pathology, a lump, bump, whatnot, patients who have very, for lack of a better word, we use this a lot in our field, bombed out teeth, meaning that it's just really on its last leg, everything's terminal there, so we have to extract the tooth and debride the site. So I see a lot of bigger cases come to me, and I see so much more. I know the patients can't actually always get the care they need, but I would love for all of us to help them.
Well, clearly, an ounce of toothpaste prevention is worth a pound of cure here for sure. How do we address that one? There's an education component to it. And Rob, I want you to weigh in on the rural context and how distance can be a disparity. But Sophie, first of all, what can be done to further educate people about the importance of all this? Because I think it's overlooked.
I think the basics is what you mentioned. So toothpaste, for instance, and a decent toothbrush, the correct size, a good, electric one would be preferable, but anything will do. And when you maintain something, it's like your car, for instance. If you get your oil change and you maintain it, it will last you for a lot longer than if you got a brand new nice car and you don't keep up with the maintenance. So that's the first step. But the second step is to also get a checkup. And, even if it's once a year, that's better than none. But twice a year is the recommended amount of visits to come to see the dentist for the generalized comprehensive checks. And then also x-rays, so radiographs. We, as clinicians, cannot see everything with our naked eye. So we need something that can actually go a little bit deeper. And a lot of patients have already had pre-existing conditions, meaning they would have had some fillings, root canals, crowns, all these things. We can't see underneath the crowns. They're metals or some sort of some material that's covering the actual tooth, natural tooth anatomy. So it could be basically decaying underneath that, and that needs attention to be addressed to take care of the patient and the tooth. But some patients would just not have that opportunity, and it just gets worse, and then they become abscess. And speaking to the young patient that passed away because of a dental abscess, I was in the hospital trained, obviously, because I'm an oral surgeon for 4 years, and that is one of the most simple but most important in time. The time matters when the patient comes in, how fast we check them, what antibiotics we put them on, how soon we intervene is very, very important.
Rob, let's circle back to where you are in Fauquier County. In a place like that, the problems, of course, that case that Sophie was just describing, that occurred in Baltimore. Obviously, this can happen anywhere. But factor in the rural nature of your clientele and how this might make it even harder to address this issue.
One thing we run into, among my patients and here in our community is that it's hard for people to get into the doctor, into the dentist, into healthcare. Transportation is a challenge. Things are farther away. There are fewer specialists in our community, and so if you need specialty care, you're often being referred to somewhere that is going to be very hard for you to get to. It's already hard to convince some people to make the choice to make their oral health important. If you put all those barriers in front of them, it's that much harder. We see all kinds of people with really just poor teeth, poor dentition, and that affects your eating, it affects your social skills, it affects your ability to interview and get a job, like facing customers. It's really a lot more impactful than people give it credit for. I also think it's hard to get children. We want to see children before they have dental problems so that they're not scared of the dentist, so that we can teach them self-care and teach their parents self-care. We have limited success getting very young children into our clinic, but we're going to keep going out to schools and spreading the message and trying to invite people and make this important. But sure, being in a rural community does make everything a little bit harder because it's just a little bit farther away and a little bit less accessible.
I'm curious, why is it so much harder to get children in the mix here?
Well, imagine, you're a single mom and you've got 2 or 3 children under age 7. Preventive care just never seems to be a priority for a lot of people because they're making tough choices every day about how they can spend their money, more importantly, how they can spend their time. How can we, if we're sharing one vehicle among multiple people, this is just not something that people bring to the top of their family priorities. But it has a way of coming up. If you don't take care of it, then it'll come back to bite you.
Be true to your teeth or they will be false to you, as my great-grandfather said that. He was in the dental supply business, believe it or not. Sophie, let's talk about the link between dental care, dental screening, and ultimately cancer. What is the importance of that, and is screening effective in this context?
Absolutely. Now, I have to preface that I'm not a head and neck surgeon, so there's different specialists that are more focused on oncology and cancer. But basically, what we need to do collectively, it starts off with the hygiene or the hygienist, where they do the regular cleanings twice a year or 4 times a year, depending on if the patient has periodontitis or not, and they check the oral cavity for anything that's suspicious. And of course, right after that, the general dentist will check the patients. And so I don't ever get to quote unquote check the patients per se, but I always get the referral. So if the dentist noticed something or the hygienist noticed something, they'll write a little referral note to me, and the patient will come with that. And I read it and see what they noticed. And most of the time, luckily for me, within my career, it's been over a decade, I've only probably seen one handful of patients that I've had to present the diagnosis of cancer to and refer them out to head and neck surgeons. But other than that, it's just sometimes just a benign lesion where the area was traumatized and it just kind of overgrew. Patients kept on re-traumatizing it. It got bigger and bigger. And sometimes it gets to an uncomfortable size. It becomes symptomatic. But I think it's very important to screen it because a lot of things look semi benign, if you will. So to compare, you can have a little white patch on the cheek or somewhere on the side of the tongue, underneath the tongue, floor of the mouth, we call it. And those areas, again, with the underneath the tongue and the lateral border of the tongue, those are very highly suspicious areas for oral cancer. But patients won't know that because it's smooth and they don't know what the anatomy should look like.
With a detection like that, Sophie, what is the next step for an individual?
It would be surgical biopsy, which means it's a procedure that we take a small sample of it. If it's a small enough size lesion, meaning we don't know what it is, but if it's small enough, we can actually excise it and completely take it out. So that would be the best case scenario because sometimes we do the surgical procedure to remove it and send it off for histopathological review by a pathologist, a different doctor, different dentist, and they send the report back saying it is cancerous. At least we pretty much took care of it, but not entirely. So then now maybe the patient needs some more treatment with lasers, or if it's a little bit more in depth, we can get scans. And so it depends on where it is. But that's the next step, to do some sort of biopsy to see what the cells are that are involved with this lesion.
Rob, just a couple of thoughts from you on what it's like to see this outpouring of need. That's just kind of right there beneath the surface. And, I presume you're going to do more of this because that's the kind of guy you are. But do you have any larger, sort of bigger scale solutions to all of this?
Well, most things come back to money in the end in this country in healthcare. If we could make things more fair and provide more opportunity for payers to, provide this kind of care, I think that would reduce the incidence of trouble. I hate to see people left out, and that's still definitely happening. As far as cancer goes, there are things we know. If you drink alcohol, if you smoke, then you're more likely to develop cancer. So there are things that we can do as, potential patients that can change our incidence of these problems. But when the door is closed or when people are not accessing care, then they get detected later in the process, and then maybe the outcome is less favorable. So the sooner we can get to everybody and get everybody in the front door, the less of these problems are going to face our families here in this country.
Yeah, it's hard to talk about prevention without that, that basic level of, screening and initial and preventative care after all, right?
It's what, Sophie was saying, some things in your mouth look kind of funny. And I'm not trained. I don't know what that is. I need somebody like my general dentist, my hygienist, or an oral surgeon like Sophie to look at that. And if they don't do that, and if I can't access that care, and months and years go by, nothing good is coming of that.
One last thing to mention, that oral cancer actually is more prevalent in males. And it's, I think it's basically one of those where depending on the anatomy and where it is, it can basically be associated one of the simple things that you wouldn't know, but it's an HPV virus that patients can get from an STD. So I want to kind of highlight that a little bit so people are aware.
Rob Marino is the executive director of the Fauquier Free Clinic, has been there for 24 years. He's also a member of the board of Less Cancer, and we're very happy to have him on that board. Sophie Oswald is a maxillofacial surgeon in Warrenton, Virginia. Thank you both so much for the good work you do. You Welcome back to the National Cancer Prevention Workshop. This year, our focus is cancer prevention in rural America, screenings and healthcare for better outcomes. My name is Miles O'Brien. I'm on the board of Less Cancer, and we have an array of guests who are focused on this particular issue of cancer, cancer risk, and in rural settings. We are joined by someone who, if you're in the town of Culpeper, Virginia, needs no introduction. He is truly a local legend and a local hero. Eugene Triplett, who is a retired pharmacist and generally great guy, but also someone who is very focused on the issue of improving health outcomes in rural America. Eugene, always a pleasure to talk to you. Thank you for being with us on
My
our
pleasure.
series this year.
My pleasure.
So I want to talk. Let's tell the story first about how you became acquainted with Less Cancer and Bill Cousins. I know there's a good story there, which has a kind of a bit of a happy ending on the issue of prostate screening. First of all, you and Bill, how did you become acquainted?
Well, I guess a couple of years ago when Bill approached, I volunteered at the free clinic, Tammy LaGraff and myself, and we were just going over. Basically, we were dealing at that time with healthy eating and how proper nutrition was responsible for less cancer. And I had always had the idea, so I participated in that, and I let Bill know about my idea of prostate screening, and then we took off from that. That's kind of how I got involved with the prostate screening part.
And so he came in and assisted you getting the word out to the community there. Is that how it went down?
My whole idea at the beginning, I talked to you about this before, was Culpeper, Madison, and the surrounding counties have one of the highest incidents of prostate cancer in the African American population. My grandfather, I found out, died from prostate cancer. My brother had prostate cancer. And it became an issue with me. And I had been working on an idea of having screenings for men at barbershops because most African American men don't go to the doctor regularly, but they basically go to the barbershop at least once or twice, or maybe off once a month to get the haircut. And so, because barbers are licensed professionals, I was trying to figure out a way to get barbers to do PSA tests on men anonymously. And so that didn't work out, but then Bill and I got together and we decided to have a workshop at one of my friends' churches.
So there were some screenings that came as a result of that. And as I understand it, there was some disease that was caught early. Is that right?
Well, yeah, we didn't get to the screenings because of COVID, but we actually had a workshop where we came in and we had a couple of physicians, a nurse practitioner, a couple of urologists come in, and they offered a workshop at the church. Didn't have a lot of men participate, but we had a lot of the women of the church participate. And because the women got educated and found out about the symptoms, the signs of prostate, BPH and all like that, they went home and told their husbands, you need to go get checked. And because of that screening, and I talked to Bill about that, 3 men from that church were diagnosed with prostate cancer, and they're getting treatment right now. And actually, like I said, 2 of them are going to the doctors that participated in the workshop.
So you've really found the secret weapon when it comes to getting men to be more proactive about their health, and that is women, of course.
That's the women. Get the women.
Men,
Women can get men to do just about anything they need them to do.
you better listen, right, or you're in trouble. But here's the
That's
thing. Men are not, for whatever reason, there's all kinds of stigmas, there's all kinds of issues associated with this, but we collectively, that is to say men, are not very good about this kind of thing, about being proactive about our health and taking preventive measures, right?
Right. I do a workshop at another church every year on men's health. And my adage is men take better care of their trucks, their lawnmowers, and their machinery than they do of themselves. They'll change the oil, they'll take it in, and
You
they'll
might be right.
But as far as going every year for an annual checkup and all, they wait until like basically with your automobile until the motor blows up and so, hey, I better get this checked out. So
Well, so we got to get around that. And then I think the particular issue of prostate cancer is even more of a challenge because I think there's even greater stigma there. All kinds of concerns that people have, and there's some embarrassment and consequences of prostate care that maybe keep people away. Tell me a little bit about that.
in African American men, the one thing and I can relate to my father and all the old adage is when you go to the doctor about your prostate, it's the finger test. It's they're going to do that, and a lot of men don't know about PSA that now you can detect it early with blood test and all like that. You still need the rectal prostate exam, but I think that's a stigma that a lot of men have, and that they just don't want to. And a lot of men assume it's just a process of aging.
So they just sort of assume it's going to happen and not do what they could do to get out ahead of it. And when you get the word to them, which is to say through the women, have you noticed, do they do something about it typically?
Yeah, I think most women, and like I said, I can relate to the three men. I know these men personally, and I know their wives, and basically the wives were at the workshop. And one wife told me, she says, yeah, my husband, he gets up 3 and 4 times a night, going to the bathroom and whatever like that. And she said, I told him you need to go get checked. And she said, I made him an appointment to actually get him to go get checked. And I said, that's when they caught the prostate. They caught it early enough. He had surgery and all. But, if she hadn't come to the workshop, he probably would have, wouldn't have got treatment early enough.
Well, that's got to make you feel good that you instigated all that. That's certainly potentially one life saved by virtue of that effort on your
Right. Yeah.
account.
Yeah.
So good on you.
Well, that we got 3 that I know of, and I don't know of the other. It could have been more than 3, but I just know personally of 3 men at that church. And like I said, it was if we just only got one, that it was well worth it. But 3 is really, really, that's a bonus.
Absolutely. So we are focused on the larger issue of disparities in healthcare in rural settings. What do you see as the biggest challenges? And and for that matter, what aside from prostate cancer, which we've been talking about, what are the diseases which ultimately might have links to cancer, which could be more easily and better addressed with a little more effort?
Well, I think one of the greatest ones that I find, especially in the African American community, is high blood pressure. There are no symptoms, there are no whatever. You don't have pain or whatever, but it leads to end stage kidney disease and heart disease and all like that. But I think the main thing is education. We have to educate. The old saying, an educated consumer. Well, basically, we need to educate people about the signs, the symptoms, and just educate them about preventing cancer. It's better to prevent something than it is to try to treat it after you have it. So prevention is the best measure.
That's what Less Cancer is all about, as you know. And I wonder, Eugene, if we could somehow clone you, because we need more people like you out there in these communities, because I know there is, there's less internet bandwidth, there's less communication capability to get good, science-based information. A lot of rumors kick around, and to have somebody like you out there giving the straight situation to people, friend to friend, word of mouth, is invaluable, isn't it?
Yes, like I said, it's as a pharmacist, I always said that one-on-one relationship with that I had with my customers and all. You can hear it on the radio, but for somebody that you personally know to come up to you and say, "Hey, we need to, you need to do that." I think that personal relationship. I mean, going back to Bill and I, I didn't know him up until 3 or 4 years ago, but I mean, it's like now we're basically best of friends, and so that personal one-on-one relationship in a community helps a whole lot. And for the African American community, the church is probably one of the greatest. I mean, that's the core of the African American community is the church.
It's funny that when I think about what you're doing, a lot of this has a way of making us think very differently about healthcare. I think we imagine doctors dispensing healthcare or this whole infrastructure of professionals. But there's a lot of people in communities like you who can really make a difference. And I wonder how to scale that up a little bit when we look at the big picture. Do you have any thoughts on that?
Well, I just get the word out, and like I said, the old adage, it takes a community, and so we need to all work together. I'm also involved with a group called Minority and Veteran Farmers of the Piedmont, and basically one of the things we're doing is providing healthy food to all of the food banks and all of the areas around here. And one of the main causes of cancer is poor diets. If we eat healthy and we clean up our environment, we can get rid of a lot of cancers right now. But it takes a collective, better nutrition, better information, accessibility to health care, and all of those things play a key role in prevention.
I think people might be surprised. Here you are, a farmer in an agricultural area, obviously. They could be food deserts, can't they?
Oh yeah, yeah, definitely, definitely. My old adage is I got a lot of sayings, but the old adage is why we shouldn't say why is good food so expensive. The adage is why is bad food so cheap, and that's kind of when people go to a food pantry or whatever, they should get healthy, nutritious produce and not some canned soup with a lot of sodium, a lot of preservatives. And so we want to give people healthy food, and that's one of the key components of preventing cancer.
So what do you do about that in a place like Culpeper, where there may not be many places for people to go to get something that is not processed and filled with chemicals? What are the options?
Well, I found out just recently Culpeper has a lot of food pantries. I mean, you can go get, food insecurity, I think, has always existed. I think COVID really manifested it. But, there are a lot of, and I have friends that teach in school, and you'd be surprised at the number of kids that they depend on getting food at school. And so if they don't go to school, they don't know, they don't get a healthy meal every day because, you got single mothers or whatever. And so, if she's only got $50, does she go out to the grocery store and buy healthy, nutritious produce, or does she go buy the Roman noodles that'll fill her kids up, keep them from being hungry, but it's not the most healthy thing for them to have that day. So, so it's a lot of factors that play into that.
We have a system generally that doesn't really focus on prevention, but this is a more particular problem where you are in a rural setting. What do you feel like there's an opportunity to really move the needle on this one?
Oh yeah, like I said, I mean, we've got to do something, and we can't just keep, we got to find a way to get it out here. I mean, I'm in a rural area, and because I'm on this today, we haven't gotten high-speed internet out here yet. They keep telling us it's coming, and it's been 2 years coming, and so rural areas are not, urban areas are high on the priority list, but a lot of and I think it's a stigma about a bunch of country folks. There's a stigma. Oh, those are a bunch of country folks out there in the area. But like I said, we need to change the outlook and how people view everybody's important, no matter who you are.
So Eugene, you impress me. You're an optimistic guy. I can just tell by the way you approach life. But at times, do you sort of feel like it's one person against a problem which is insurmountable, too big?
Nothing's too big. I mean, I'm also, by trade, I'm a farmer, I'm a pharmacist, but I'm also a minister. And my old adage is, God says there's nothing impossible for God. And so one of the things, I mean, he can do anything, but he needs our help to do it. So,
Well, somebody say amen to that for sure. Eugene
oh yeah.
Triplett, we are so grateful that you're a friend of Less Cancer in general and Bill Cousins in particular. And we whatever we can do to help you in your mission, one person at a time. We can do this, right?
Right. And I talked to Bill before. We've been focusing on men's health, but I think we have to focus on all health, women's health, children's health. All you'd be surprised at the number of children that suffer from cancer. And I mean, it's we look at that and you see it on TV and all, but we got to focus on everyone.
All right. Pharmacist, Reverend, local hero, Eugene Triplett, what a pleasure to talk to you.
My pleasure talking to you and being a part of this Less Cancer program, because I think it's something that we need more of. And thank you, Bill, for involving me. And I look forward to working with you in the future on a lot of other issues.
All right. This is the National Cancer Prevention Workshop produced by Less Cancer. We're focusing this year on cancer prevention in rural America, screenings and health care for better outcomes. And Eugene Triplett is a big part of the solution. I'm Miles O'Brien. Thanks for watching. Welcome back to our continuing series for the National Cancer Prevention Workshop produced by Less Cancer. This year, we're focusing on cancer prevention in rural America, screenings and healthcare for better outcomes. I'm Miles O'Brien. I'm a board member of Less Cancer, and we are talking to thought leaders in this space. And our next guest is going to help us understand how distance is a disparity. She is the Chief Scientific Officer and Executive Director of Comprehensive Cancer Center at the Huntsman Cancer Institute in Salt Lake City. Nelly Ulrich, thank you so much for your time. We appreciate it.
Thank you for having me today. I'm really delighted to talk to you about this.
So we've been talking about rural populations. You have what you call frontier populations. Walk us through that. You're in a part of the world where population density is quite sparse, and it complicates matters, doesn't it?
Absolutely, it does. And so just to set the stage, Huntsman Cancer Institute is located in Utah, but we serve actually 5 states in the Mountain West, including Montana, Wyoming, Idaho, Nevada, and of course, Utah. And many of those states are really having many dispersed populations, including frontier populations. Montana and Wyoming are examples of that. And what does that mean? I mean, let me start out first by talking about patient care briefly. So a distance can be a disparity. For example, if one of our patients has to come here for radiation treatment, they come repeatedly, but often they have to go over mountain passes, they have to drive many, many hours, and they do that while they have side effects such as diarrhea. And that is very, very challenging for them. And so we're looking to figure out how can we improve both prevention and care as we serve these vast areas in the Mountain West.
Well, so just as a definition, what would you call frontier, and how does that compare on population density to what we would classify as rural?
Yes, so rural is typically classified as fewer than 100 people per square mile, and frontier is fewer than 7 people per square mile. So it's a lot of nothingness, and it means like for every activity that you're doing, whether it's going shopping or whether going to school, there's transport involved. And for healthcare, of course, there's distance that has to be overcome.
And the distances can be quite daunting. As you say, not just the mountain passes, but just the outright numbers are daunting as well, right?
Yes, many of our patients travel more than 500 miles to come here. And what is also interesting, you think, oh, you could just take a plane. With some diseases, like some leukemias, you're not able to take a plane. You have to drive. And you can imagine that distance is already a challenge. But when the weather is bad and there's a snowstorm, many of those freeways are not even getting cleared. So we really try to facilitate everything for our patients when they come here to have everything like a one-stop shop. And of course, we use different ways to then continue their cares at their home.
So let's talk a little bit about the population, who, what your demographics here. I imagine, especially in your part of the world, and when you're talking about frontier populations, probably a fair number of Native Americans, but give us a sense of who you see that live in these sparsely populated areas.
Yes, absolutely. We have, of course, many rural white individuals, but we also have a large Hispanic population, and we have 43 tribes and nations who we serve. And we have specific programs to reach out to them and work with them. We have a special populations program that is focused on Native Americans.
What other complications come up when there's such an amount of distance? Is it as you say, if you're trying to get treatment and you have all the consequences of chemotherapy, the idea of being in a car for 8, 9, 10 hours, it's just kind of mind-boggling. But when you start talking about issues like screening, that gets complicated too, because a simple mammogram becomes a 2 or 3 day event, right?
Yes, absolutely. And think about if you want to get a mammogram, but you're also a mother or a grandmother and you're taking care in addition of the farm and you have to travel to get that mammogram. So what we did find in surveys, the first
Welcome back to our continuing series for the National Cancer Prevention Workshop.
Thank you to Less Cancer for inviting me to speak at your annual National Cancer Prevention Workshop. My name is Abigail Spanberger, and I am proud to represent Virginia's 7th District in the U.S. House of Representatives. I want to take a moment to thank Less Cancer for the wonderful work that you have done in my district, especially in Culpeper. In 2022, Less Cancer worked with the Culpeper Police Department, the Free Clinic of Culpeper, and Healthy Town Culpeper to provide free cancer prevention screenings. Since then, I have heard great feedback about this effort. Thank you for your commitment to keeping our community safe and healthy. Like you, I believe that we must combat cancer. We must invest in prevention methods. We know that early detection of cancer significantly increases survival rates, yet too many Americans cannot afford the life-saving and emerging prevention methods, such as blood-based tests. That's why I'm committed to advancing legislation that improves access to innovative prevention screenings for every American, no matter where they live or their ability to pay. Thank you for allowing me the time to speak with you today, and thank you for your continued advocacy. It is an honor to see the incredible work that this Virginia-based group is doing across the country, and particularly the work that you all have done in the 7th District and across the Commonwealth of Virginia. Thank you for your work. I wish you continued success.
Welcome back to our continuing series for the National Cancer Prevention Workshop produced by Less Cancer. This year, we're focusing on cancer prevention in rural America, screenings and healthcare for better outcomes. I'm Miles O'Brien. I'm a board member of Less Cancer, and we are talking to thought leaders in this space. And our next guest is going to help us understand how distance is a disparity. She is the Chief Scientific Officer and Executive Director of Comprehensive Cancer Center at the Huntsman Cancer Institute in Salt Lake City. Nayeli Ulrich, thank you so much for your time. We appreciate it.
Thank you for having me today. I'm really delighted to talk to you about this.
So we've been talking about rural populations. You have what you call frontier populations. Walk us through that. You're in a part of the world where population density is quite sparse, and that complicates matters, doesn't it?
Absolutely, it does. And so just to set the stage, Huntsman Cancer Institute is located in Utah, but we serve actually 5 states in the Mountain West, including Montana, Wyoming, Idaho, Nevada, and of course, Utah. And many of those states are really having many dispersed populations, including frontier populations. Montana and Wyoming are examples of that. And what does that mean? I mean, let me start out first by talking about patient care briefly. So a distance can be a disparity. For example, if one of our patients has to come here for radiation treatment, they come repeatedly, but often they have to go over mountain passes, they have to drive many, many hours, and they do that while they have side effects such as diarrhea. And that is very, very challenging for them. And so we're looking to figure out how can we improve both prevention and care as we serve these vast areas in the Mountain West.
Well, so just as a definition, what would you call frontier, and how does that compare on population density to what we would classify as rural?
Yes, so rural is typically classified as fewer than 100 people per square mile, and frontier is fewer than 7 people per square mile. So it's a lot of nothingness, and it means like for every activity that you're doing, whether it's going shopping or whether going to school, there's transport involved. And for healthcare, of course, there's distance that has to be overcome.
And the distances can be quite daunting. As you say, not just the mountain passes, but just the outright numbers are daunting as well, right?
Yes, many of our patients travel more than 500 miles to come here. And what is also interesting, you think, oh, you could just take a plane. With some diseases, like some leukemias, you're not able to take a plane. You have to drive. And you can imagine that distance is already a challenge. But But when the weather is bad and there's a snowstorm, many of those freeways are not even getting cleared. So we really try to facilitate everything for our patients when they come here, to have everything like a one-stop shop. And of course, we use different ways to then continue their cares at their home.
So let's talk a little bit about the population, what your demographics here. I imagine, especially in your part of the world, and when you're talking about frontier populations, probably a fair number of Native Americans, but give us a sense of who you see that live in these sparsely populated areas.
Yes, absolutely. We have, of course, many rural white individuals, but we also have a large Hispanic population, and we have 43 tribes and nations who we serve. And we have specific programs to reach out to them and work with them. We have a special populations program that is focused on Native Americans.
What other complications come up when there's such an amount of distance? Is it as you say, if you're trying to get treatment and you have all the consequences of chemotherapy, the idea of being in a car for 8, 9, 10 hours, that's just kind of mind-boggling. But when you start talking about issues like screening, that gets complicated too, because a simple mammogram becomes a 2 or 3 day event, right?
Yes, absolutely. And think about if you want to get a mammogram, but you're also a mother or a grandmother, and you're taking care in addition of the farm, and you have to travel to get that mammogram. So what we did find in surveys, the first surveys of our frontier populations, that people really care about cancer care and cancer prevention, and they want to make this a priority. But what we try to do is also bring our opportunities for care to them. And so, for example, we have a mobile mammography bus, and that has traveled already thousands of miles to bring mammography screening to our patients. And they've been to places where there's no services, no federally qualified health center, no other care. And they've seen hundreds of patients, many of which who had their very first mammogram through this setting.
So the good news is people want this. They understand the value of screening and prevention. Is there further education which needs to be accomplished?
There's definitely valuing for prevention and care from what we have seen, but we just want to point out that those groups of people, those populations in the Mountain West have not really been listened to very much. Many of the surveys that have been done have not really covered those populations. We're just now understanding from a very first broad survey on health behavior, science communication, and healthcare, what they need and what they want. And we have also organized a Mountain West Summit. So there's a lot more that we really need to understand in order to best provide the services and help and connect.
Well, a lot of this too, when you're trying to identify such a remote population, to understand, it's difficult to do a focus group, put it that way. So how are you able to even get that kind of data on what they need?
Well, we actually have many partners across the Mountain West, the cancer coalitions, the federally qualified health centers, and we did a survey with a Wyoming institute. But the survey is just one piece of information. We absolutely do something we call focus groups, where we bring people together, and the objective is to listen and to learn from our side, because often we make assumptions that are entirely wrong. And that has been also very successful with respect to HPV vaccination. We have done a lot of work on trying to elevate the HPV vaccination rates here in the Mountain West.
HPV vaccinations in general, became so controversial in the midst of the pandemic. Are you able to get some good, solid, science-based information to this population?
Well, it's absolutely a dialogue, and it's a dialogue that has to be very respectful and caring. And one thing that everybody cares about is their kids. And so sharing with them what we can do to help their children to avoid having in the future cancer, but also maybe infertility because of sequelae of HPV complications. So I think we just, again, we have to listen, to learn, and then understand how can we best communicate. And yes, the national landscape has not helped, but we find that in a one-on-one dialogue, especially with the healthcare providers, we make a big difference.
So during the pandemic, we all learned about having a dialogue with our healthcare providers electronically, and that was, truly a silver lining out of the pandemic was everybody getting accustomed to this on both sides of the equation. How much are you leaning into that idea? And when you're talking about frontier populations, I imagine there are other complications, just simple bandwidth and technology, and the ability to even do telehealth must be limited. But I assume that's a key part of what you're doing.
Absolutely. That's exactly what Huntsman Cancer Institute's mission is, to deliver this cancer-free frontier through transformation in healthcare delivery. So we're doing a lot of research on how can we use telehealth and different other ways to engage and what we call is like bring care to people's homes. We have a program called Huntsman at Home, where we have continuous care for our patients and avoid that they have to come to an emergency department for any complications. So this has been in rural Utah, for example, and we just realized that there were like more than 50 situations where they normally would have been advised to come to an emergency department visit, and they were able to stay at home through care that we were able to provide targeted in this setting through some nurses. We also do a lot with telehealth is critical right now. As you alluded to, in many situations, there is no bandwidth. So we have to work with that. And we work with symptom assessments basically through the phone. And that works quite well. And in addition, we use transformative new ways like artificial intelligence to just monitor what's reported in terms of those symptoms and identify patterns that enable us to then come in and prevent and say, oh, wait a minute, here's something going to happen that we have to step in for. So we're trying to be as innovative as possible and make this really a big part of our research activities.
Okay, I'm pretty fascinated about the idea that artificial intelligence can help you with this. Can you be a little more specific about how it actually would be employed?
Well, it has been successfully tested in predicting who will get an asthma attack. And so a brand
Wow, that's fascinating. And is that like akin to a large language model, or is it pattern recognition? What's going on?
It's pattern recognition through electronic health records. And in this case, for us, we are using it, and this is research, right? This is where we just are trying to go and evaluate this, but it's a partnership here at the university with some of our informaticians, AI specialists, and our Huntsman Cancer Institute Cancer Center members who work together to think about that. So it's pattern recognition of what data do we assess on our patients remotely. And that is happening, and then will enable us to step in if we say, here is a red light coming on. So it's basically a way of using AI for triage of a lot of data.
That's fascinating. I know AI is making a big impact on, the ability for radiologists to look at images and it can see patterns and problems long before the human eye can pick them up. So this is akin to that, where you can sort of get ahead of things way before a phone call would give you any clue.
Yes, exactly. That's one other opportunity. And I do honestly think that AI will give us so many opportunities. I know there are concerns that we have to sort out, but for remote care, for being able to help patients who are 500 miles or further away, it really will help us to transmit images that can be seen, that can be reviewed very quickly as part of an initial process without even a person yet being there before the physician comes in the room or virtually in the room. And that's, I think, is a huge potential for helping our rural and our frontier populations.
It's a huge challenge when you consider the amount of, you have a lot of turf, don't you? Do you get a bit overwhelmed by it all?
Well, we set out to do this because there's no other NCI designated cancer center in that region. This is really our job. We call it the area we serve because we're passionate about it, and we work on it in various domains with many, many partnerships. And it ranges from like the screening bus and research activities, for example, with Montana State University. But it also means that we work with our politicians to overcome barriers that exist across state borders.
Let's talk a little bit about Medicaid and its influence in all of this. It is expansion of Medicaid a key in your view?
Absolutely. I mean, Medicaid is such a central mainstay of healthcare for many of these underserved populations. And it would help us a lot to provide better access to screening and to preventive services, and of course to care if people had universal health coverage or at least Medicaid.
And that goes back to your comment about the politicians. That's a message that we need to make clear to our political leaders, that Medicaid is not so much an expense as it is an investment.
Yes, and absolutely. And I have to say, we've spent time on the Hill visiting with senators from the 5 states, and it's been overall a great experience. They really are excited to hear that we care, that the NIH cares about this area, the new NIH directors from Wyoming, and so that people are listened to and that we're trying to make a difference. So we can, in this context of saying we want to combat cancer, bring up Medicaid as one example.
It's difficult in your part of the world. You're in the red states, and these issues of Medicaid become very complicated, don't they?
Yes, and I have to say, I'm not an expert on it, but I have to say that cancer is something that unifies across party lines. Mr. Huntsman, who was our main philanthropist, worked on the Hill, and he said, I'm from the Cancer Party, and it doesn't matter whether we are red or blue. And every second man, every third woman will get cancer, whether they're Republican or Democrat. And so we work with everybody to improve the case.
Cancer is a bipartisan killer, isn't it? That's really what
Absolutely. It's a bipartisan killer. And maybe there's one thing I also want to highlight that has been important to us is to educate by also providing access and opportunities to the next generation that is growing up far away from opportunities that kids have who are living in cities. And so we have programs to bring them here to learn about what research is, what clinical care is, to provide pathways for their careers. And we also work with them through programs that are interactive with colleagues in New York City. So they talk to kids and teenagers who are coming from a very different background. So we really see that as our mission to advance a cancer-free frontier.
Little different population density, huh?
Different population, but now here's one thing. So think about a cancer patient in New York City will have similar challenges in coming to care if they are immunosuppressed. They don't want to use the subway. They cannot drive. And for them, telehealth or ability to have remote care is just as relevant and helpful. So what we learn here can be quite relevant for the rest of the nation.
A different kind of canyon to travel through, for sure. All right. Nelly Ulrich, who is with the Huntsman Cancer Institute in Salt Lake City. Thank you for all the good things you're doing to try to bridge that disparity gap that relates to distance and population density. Very important work. Thank you for your time.
Thank you very much. I really appreciate it.
This is the National Cancer Prevention Workshop produced by Less Cancer. We're focusing this year on cancer prevention in rural America, screenings and healthcare for better outcomes, and people like Dr. Ulrich are doing just that. I'm Miles O'Brien. Thank you for watching.
Hi, everyone. I'm Congressman Chris Pappas from New Hampshire. I'm really pleased to join Less Cancer once again as you highlight the importance that education and advocacy holds in reducing the risk of cancer. Thank you to the Board of Directors for your dedication to this cause, and I'm grateful for all the organizers of this event, including my friend Mindy Messmer, for making this possible. Less Cancer uses 3 approaches to cancer prevention: reaching out to the public, advocating for change, and participating in public discussion. National Cancer Prevention Day combines all of these approaches to raise awareness and reduce cancer risk in our communities, and that goal couldn't be more personal to each and every American family. In New Hampshire, we have some of the highest cancer rates in the country, and we know we have significant concerns about environmental hazards, including PFAS contamination that is linked to cancer. As a member of Congress, I've led a range of efforts to secure clean drinking water, to clean up contamination, and to hold polluters accountable. As a member of the Veterans Affairs Committee, I was also pleased that we were able to pass the Honoring Our Pact Act, which is expanding health care for veterans that have been exposed to toxic substances through their service to our country. There's so much more work to do on a range of fronts, and we won't be successful in lowering the incidence of cancer without your continued engagement and work. So I look forward to continuing to hear from Less Cancer about the steps that we can take in the policy arena to encourage prevention and protect public health. And I just want to thank you once again for coming together, for sharing your stories, for devoting your time and efforts to this cause. And thank you for standing up for your families and your communities as we work together toward a world with less cancer. Thank you and take care.
Hi, I'm Congressman Dan Kildee. Thank you to Less Cancer and Mindy Messmer for inviting me to speak with you today. I'm grateful for the critical work Less Cancer is doing through the National Cancer Prevention Workshop this week. For those of you who don't know, I recently had a cancer battle of my own. In March, during a precautionary scan, doctors found a tumor in my tonsil. After surgery and a long recovery, I'm happy to report that I'm cancer-free. But if it wasn't for early detection, my prognosis could have been much worse. There are countless other stories just like mine that show that early detection saves lives. Unfortunately, many Americans don't have access to the same preventative health care. And that's why I'll continue fighting to clean up toxic cancer-causing chemicals like PFAS and remove barriers to high-quality health care for everyone, no matter their zip code or their income. And I look forward to working alongside each of you in that fight.
Thank you to Less Cancer for spearheading the National Cancer Prevention Workshop. All of us know someone in our families or friends who have been affected by cancer. This is personal, and we need to do a better job as a country in preventing cancer and screening it early. That's why I so admire the work you're doing. In my state, we have a program which screens for women in underserved communities to make sure that we're detecting cancer when we can, because we know if we catch it early, it is treatable and often curable. We also have worked with Mindy Messner and others on PFAS and reducing the cancer risk of PFAS. I hope this year we all will come together to make sure that we do what we can, particularly in rural and underserved communities, to prevent cancer. Thank you again to Less Cancer and Mindy Messner for the work you do.
Hi, I'm Congressman Paul Tonko, representative of New York's 20th Congressional District. And thank you to Less Cancer for spearheading the National Cancer Prevention Workshop. It is an honor to work alongside such dedicated advocates who share the goal of a world without cancer. As ranking member of the Environment Subcommittee on Energy and Commerce, I am focused on ensuring that we enact the right protections against environmental and toxic chemical causes of cancer, which too often impact our most vulnerable populations. I am also proud to support legislative efforts aimed at increasing early detection, including the Find It Early Act that would help address insurance barriers to breast cancer screening and ensure that costs don't delay testing and detection. And across my state of New York, initiatives such as free mammogram vans and streamlined transportation to healthcare facilities have made powerful strides to improve access to care. While there is still much progress yet to be made, I will continue to support policies that strengthen the ACA, improve health care for every American, and support rigorous research and development of cancer treatments. I am thankful indeed for the advocacy of Less Cancer in helping individuals lead healthier, cancer-free lives. And with that, thank you again.
Hey everyone, Brian Fitzpatrick here from Pennsylvania's 1st Congressional District. I wish I could be with you in person today, but I wanted to thank Less Cancer for leading this National Cancer Prevention Workshop. As you all know cancer is the second leading cause of death in the United States, and it's very personal to me as I lost my brother and my best friend Mike to cancer several years ago. It is imperative that we expand awareness about the critical significance of cancer prevention, particularly in rural areas. The current funding levels for research do not meet the alarming rate at which Americans are dying from this disease. That's why I led and authored the bipartisan KO Cancer Act, which significantly increases the funding for cancer research for the National Cancer Institute to more appropriately align with the current cancer mortality rates. One of the most effective ways that we can improve outcomes is by increasing accessibility to early detection screenings, which is why I introduced the bipartisan Access to Lung Cancer Screening Act, which takes critical steps towards increasing lung cancer screening rates across the country while reducing barriers to preventative care, particularly in underserved areas. Lung cancer claims the most American lives annually of any form of cancer, accounting for nearly 25% of cancer deaths. In addition to introducing that bill, I also introduced the Screening for Communities to Receive Early and Equitable Needed Services for Cancer Act, also known as the SCREENS Act. This legislation improves access to screening services, particularly for breast cancer and cervical cancer, making it easier for vulnerable populations to get the preemptive care that they need. And lastly, I introduced the Access to Breast Cancer Diagnosis Act of 2023. This bipartisan legislation makes breast cancer diagnostic tests more affordable and accessible to women by eliminating copays and additional out-of-pocket expenses. I want to thank Less Cancer Foundation for spreading the word for all the work that you do in educating our healthcare providers, at-risk populations, low-income communities, and workers to stop cancer at its source. As a co-chair of the House Cancer Caucus, I will continue to fight for legislation that boosts funding for cancer research, supports patients, supports survivors, and supports families, and also to bolster prevention efforts across the board to ensure that cancer disparities are eliminated once and for all. I look forward to continuing to work with you in this fight. Thanks for having me, and God bless.
Hi, I'm Congresswoman Terry Sewell, and I proudly represent Alabama's 7th Congressional District, which includes the historic cities of Birmingham, Montgomery, Tuscaloosa, and my hometown of Selma, Alabama. To begin, I want to thank Less Cancer for spearheading the National Cancer Prevention Workshop. Reducing health disparities and ending cancer continues to be among my top priorities in Congress, but no one can do this work alone. Your efforts save countless lives each and every day. We know that one of the most important ways to beat cancer is to catch it early, before it spreads. Thanks to the extraordinary scientific progress, we have more tools than ever before to do just that. Indeed, emerging early detection tools hold the potential to transform the fight against cancer by screening for multiple forms with a single blood test. In Congress, I am proud to be the lead sponsor of H.R. 2407, the Nancy Gardner Sewell Medicare Multi-Cancer Early Detection Screening Coverage Act, to ensure that our nation's seniors can access these tools when they become available. I am thrilled to report that H.R. 2407 is gaining momentum daily and now enjoys the support of a bipartisan majority of my colleagues in the House of Representatives, 238 members, and 36 members of the United States Senate. I want you to know that I am committed to harnessing this progress, to push this bill across the finish line, and to get it to President Biden's desk. The fight against cancer is personal for me, as I know it is for so many of you. What keeps me up is knowing that what we do today will save countless lives in the future and pave the way for a world without cancer. To the advocates and experts, thank you for your commitment to this worthwhile cause. After all, change rarely comes in the halls of Congress. Rather, it bubbles up from hard work and dedication of people like you, fighting to make our world a better place. I firmly believe that early detection is going to be our best chance at reducing the burden of cancer. Together, let's continue this fight until cancer as we know it ends. Thank you again, and best wishes for a successful workshop.
Hi, everyone. It's Congresswoman Debbie Dingell from Michigan's 6th District. I'm honored to join Less Cancer again this year for the National Cancer Prevention Workshop and discuss the importance of expanding access to preventative services, especially for rural communities. Supporting survivors, their families, and working towards eradicating this disease makes such a huge difference. As co-chair of the Bipartisan Cancer Prevention Caucus, I've worked with colleagues across the aisle to support education and awareness efforts and advance policies that'll bring us closer to a world where cancer is considered a preventable disease, providing hope to millions of Americans by focusing on ways we can stop cancer before it starts. Too many Americans face a heightened risk for adverse health outcomes based on their zip code, their income, and their race. We know when individuals lack access to quality health care, they risk foregoing critical preventative care. They can't afford it, so they simply don't get it. And that means the difference between life and death. One important way we can address rural health disparities is by funding and prioritizing community health centers. Community health centers are the closest thing we have for fully accessible care now in the United States and provide invaluable services to so many in the community who might otherwise not have access to high quality care. I make this commitment to you. I'm going to continue to work in Congress to ensure community health centers are protected and they're funded. Thank you again for your work and your partnership. I'm always going to be in this fight with you.
Hey, everybody. My name is Bill Cousins. I'm the founder of Less Cancer. I wanted to jump on here today and thank you for your support of this amazing workshop. We, as founders of National Cancer Prevention Workshop, have also initiated National Cancer Prevention Day and the U.S. House Caucus on Cancer Prevention. We're so grateful that we've had the support for 2 decades, and we are now starting to really see the light at the end of the tunnel, and prevention is becoming much more a mainstream solution for cancer than ever before. But this could only happen with you. Our organization is a totally grassroots organization. I tell people all the time we're funded on bake sale money. We don't have big sweeping grants. We don't have big corporations behind us. This has been an effort of several thousand people that have made this happen, and we are so grateful. Thank you all for joining us today, and thank you for being part of the Less Cancer community.